Good afternoon, everyone. Welcome to the Public Health PBRN monthly virtual meeting for November. I'd like to welcome everybody, especially those new members this will be your first monthly virtual meeting for the PBRNs. Welcome. This month we are going to have Dr. Betty Beckmeyer from the University of Washington and the Washington PBRN present on the Public Health Activities and Service Tracking Study, or the FAST study. Betty, are you on board?
I'm here.
Excellent. Just to let everyone know, Dr. Mays will be here in just a few minutes. He is actually finishing up a session it's hard to keep track of where he is. I believe he's in Tennessee today, but he'll be on in just a few minutes. So, Betty, if you just want to go ahead and get started, I think we have a good group on board, so take it away.
All right, and Lizette, am I able to advance the slides on my own?
Yes, you can with the right arrow on the bottom of the gray ribbon bar on the left side.
Okay. Hang on. Okay.
There you go.
All right. Okay, thank you everybody for having me. Since these PBRN monthly webinars are sometimes billed as a work in progress, I'm going to take that very literally here, and hope you'll bear with me as I'm really kind of giving you a taste of what we've been doing right now in terms of a project connected with the Public Health Activities and Services Tracking Study, which we lovingly call FAST, and give you a sense of where we are with this right now. So this is not necessarily all ready for prime time, but it's an opportunity, I think, for us to get some feedback from some of you in terms of how to interpret some of what we're seeing and where to go next with some of this as we dabble around in the data we're working with. So first I'll give you a little bit of a background, quick background to FAST, a little overview of what we're doing. I'm gonna talk today about FAST, what we call, quote, FAST finance in particular, the finance data we've been looking at. I'll touch on what we've been seeing with maternal child health expenditures, environmental health, and communicable disease control, and then I'll talk a little bit about other directions for this FAST finance piece. There's other things going on with FAST as well, which I won't touch on today. We could do that at another session, but I'll focus on this one RWJ-funded PHSSR grant that we've been calling FAST Finance. So a quick reminder about FAST in particular. The FAST project is really kind of, well, what is it? It's sort of a data repository, a database available as a resource for a multidisciplinary research team involving public health practitioners, and all aimed at answering questions around what works, and in terms of specifically focused on local public health departments and public health systems, what works for what populations under what conditions. And these data are increasingly being used by other researchers, which is all kind of what we've been hoping for and working towards. And its development so far has been really dependent on and integral to the public health PBRNs. The piece I'm going to talk about today is really this diverse research team, or the research we're doing with some of these data. There's other side activities that have really happened in terms of the more we put these data out there, the more they become of interest themselves for public health practice and for decision making. So there's been some really fun kind of side projects going on with that. But today I'm going to talk about some specific research we're doing, and we really do have quite a diverse research team. I just came from a little celebration brunch we were just having in honor of us finally pushing out a big grant that went to NIH just this week in relationship to some of the work that we're doing, and some of you are aware of that as well and have been involved. But this work is really absolutely a collaborative process. The The data themselves are usually administrative data for FAST, not just expenditure data, but we're really wanting to focus more and more on public health services data, which involves improve and other work. Today I'm going to be talking about administrative data in terms of finances. But these data are owned by our public health practice partners. So it's their data, and we're working with interested statewide groups around the state here in Washington. In particular, this is how I got started in this whole business, is through interest here in Washington. Our practice partners, they understand and know what's behind these data, and they are interested in using these data for their own decision-making priorities. At the same time, we've got this database we've been building, have been able to manage these data in new and different ways, and working together with our practice partners to analyze these data, and we provide links to practice or links to resources and grant opportunities, et cetera. So it's been a really tremendous collaborative process or partnership. So in terms of them focusing in on this vast RWJ-funded project for FAST Finance, the larger project is really looking at variation of local health department investments relative to need and economic change, of course, incorporating the financial downturn as well. And it's got these three areas of service that we've been looking at: maternal child health, environmental health, and communicable disease control. We've involved, from the start, we involved 4 states, Washington, Florida, Minnesota, and Ohio. And those states have been involved. We just have been bringing on New York very recently. I'm not going to talk about our New York data yet. And in part, a lot of what I'm going to show you today is not the most hot off the presses, and there's a reason for that, because the most hot off the presses we're going to be showing to our 4 state practice partners, 5 states now with New York, in a couple of weeks, in a week or two. And we really want to talk through these data with them first, and out of respect for them, they as part of our more immediate research team. So I'm showing you work that we've talked through with them already, but it won't incorporate data from New York, for example. I will show you what we've found with maternal child health. Some of you have seen us or me present on our findings from our maternal child health study. We really did. We're able to make pretty interesting links between local health department expenditures on MCH services and their impact on health outcomes for populations at risk. That was really at the end of the day, our research question about maternal child health services. And we started there in part because our practice partners were really upset, and understandably so, around maternal child health services being cut so dramatically in some of our states. But the takeaway, I'm not going to dwell on that study because I've presented it elsewhere, and actually there's a paper coming out hopefully pretty soon on that. But the bottom line was that local health department expenditures really did appear to have an independent impact on birth outcomes, and in particular low birth weight. This effect varied by population served, and it appeared to really be especially true for populations in poverty, counties with high poverty. The strongest effect was seen in our sample of Washington poor jurisdictions. While significant findings weren't seen consistently in other segments of our sample, we really considered it noteworthy that we detected significant effects when the variation and change over time actually was of these outcomes was actually pretty small and flat, but it really suggested that the signal or the significance is there in other counties, but it's blocked out to some degree by noise in the model in some parts of our sample. So sample counties that were just more heterogeneous were tougher to see that direct a relationship between the services and the outcome. But we were able to see that more in particular in Washington and some of the poor counties where there's just a less heterogeneous population, and it was more clear, more obvious, more detectable. And the findings where we also saw the findings in more proximal outcomes, that outcome of low birth weight. It was most directly related to really targeted expenditures around WIC, family planning, and basically maternal and infant child health services. It was a pretty direct relationship with low birth weight. Less direct with, for example, infant mortality, but there's where we saw total expenditures of a health department had a relationship there. The implications of all this is that really reductions in maternal child health spending appear to impact birth outcomes, and this is extra important, it would seem, given the cuts to services. And in a related study, we saw that the services were being cut inversely proportionate to where the need was increasing. So this gives us all pause and practice in terms of advocating for those kinds of services. Also, it was the takeaway to us was that that you really could do some interesting things with these data. That public health practice-based research networks really do have detailed and existing data that are key to advancing public health systems research. So that was a very exciting takeaway for us. At the end of this talk, I'll have related references and some of our papers that have been published, and ones that are getting there or hopefully to be published soon. I'm going to talk a little bit about environmental health. We don't have, this one really is more of a work in progress, but I'll give you a snapshot of some of what we're doing here. Here's our model. One thing I realized, I just was thinking to myself that I forgot to put in here, that under local health department services, we also have 3 classes. That's a whole nother talk, really, about these 3 classes of health departments that we're able to develop around local health department services as well. But in terms of environmental health, we're really looking at environmental health expenditures for 3 states, Washington, Florida, Ohio, and then have now added New York. And our outcome has been to look at enteric food and waterborne cases, number of cases, and then we've been focusing more lately on salmonella and E. coli. And then we've got these covariates. The grayed out ones are ones that we would love to have and have looked at ways of getting these. We've actually included, there is a percent food workers variable that we've dug up and have been playing around with that one. Some of the other local health department service variables are ones that might be in our future, but have been a little hard to come by, as some of you can imagine. CBSA on the far right-hand side in terms of covariate, if you're not familiar with that, that's core-based statistical area. That's rural, micropolitan, and metropolitan, basically. So that's basically our model we've been using. It's been a tough row to hoe, to tell you the truth, in terms of getting to that or finding relationship with the outcome. And so we're almost to where we're trying a major plan B. There is just a lot of unobserved action going on that's been really tough and understandable. These data are only so good, and we're really trying something that may or may not work here. But in part, it's because it speaks to the need for more and better data and for some standardization around some of this, around some of the data we collect in our health departments. But nonetheless, we've been trying, and here's what some of you may have seen this slide before, but it's an example of what we do with the data in terms of crosswalking it from one state to another. In terms of environmental health, you'll see Ohio has what we call our big bucket of environmental health expenditures are really all kind of in one big bucket, so that limits the analysis some. We're thankful, actually, bringing New York on has added a lot of additional detail as well. So we'll be able to do some analysis with the 3 states and a larger level analysis with 4. But that's a lot of painstaking work there in terms of looking at data definitions, et cetera, and how similar can we make, how comparable are these service codes around these expenditures. Once we do that, we can start also looking at the data by state and across the states. We're really not interested at the state level actually, but here's a way we start by doing a lot of descriptives and looking at the data in a variety of different ways. We're interested in looking at variation across local health departments, but here's an average of local health department per capita expenditures, or this is total expenditures. We'll often look at it per capita and inflation adjusted. And you see here our environmental health people have been really interested in looking at the distribution of these service expenditures and over time. Here's 11 years. And then here's Florida. And you can look a little bit at the difference. I'll go back and forth a minute here. And you see the categories are very different in terms of where the money is coming from and going. And a lot of that has to do with policy differences and structural, operational differences in the states, et cetera. But also when there were increases and decreases is very different. And these are just our way of exploring the data, and we use these to talk about the data with our practice partners. The meeting I said we're having in a week or two is an effort to do that, to talk about the data with our practice partners in terms of why are there these differences? Why might there have been this? What does this dip or that dip represent? What's going on there that we should know about? What would you like to explore further? Here's where we look at the data together in terms of local health department expenditures and enteric diseases. We did a combination of the leading seven leading enteric diseases in these states. The bars are disease rate, the 7 leading enteric diseases. You'll see Florida has the higher disease rate, the yellow bar, always the highest in enteric diseases. Ohio and Washington, you see the disease rate moving somewhat similar to each other until about 2009. The horizontal lines are per capita environmental health expenditures. You'll see the environmental health expenditures are pretty similar throughout for Ohio and Florida, but Washington is very different, particularly later on. So the disease or the bars versus the expenditures, you can look at that for a long time and really there's not a lot of apparent relationship there, and for a lot of reasons that we've been identifying and talking about with our practice partners. But it also makes one really wonder about, it underscores some of the tremendous difference. What we find is less of a difference over time in these expenditures and what have you than there is geographically, not just by state, but within states as well. Tremendous amount of variation within states and across the states. So here's communicable disease, and I'll touch on this one a little more briefly. So here's us looking at per capita communicable disease control expenditures by, again, here by CBSA. CBSA is metropolitan, micropolitan, and rural, and then the dotted line there is combined. Here you see Minnesota, and now we're doing the same with New York for here as well. Here we take a look at it. It draws our attention to the tremendous difference in terms of how the states are in terms of where the money is for rural communities, for example. Here, Florida, notice that Florida rural per capita expenditures is way less than those in the other areas. And in Washington, rural per capita expenditures is more than others. Quite often you tend to think it's going to be more in the rural areas where they have less economy of scale. But it's flip-flopped here. And Minnesota, as a third example, they're all very much the same, very similar, and all very consistent over time. So it makes one wonder what's going on there. What should we be taking into account when we look at these? As we pull these data together, we really then want to look at, as much as possible, look at an aggregate of all these states and their locals together, as a combination together. And we might look at differences between these couple hundred health departments, and how they might vary by rural, urban areas, and in relationship to other factors in a community, et cetera, but not just by state. Our interest is really at the local level. And here's another thing we do in terms of looking at these per capita expenditures. Not surprisingly, Minnesota's at the, these states operate very differently, and we see Minnesota's blue line lower down here, as we saw on the previous slide. And then we look at this in relationship to mean communicable disease mortality here, and just exploring the data. The communicable disease mortality here really represents largely flu and pneumonia. That's what really makes up a huge amount of the communicable disease mortality. But next steps, we'll be looking at some other disease rates, et cetera. We've been very eager to look at immunization rates, knowing that local health departments play a big part in immunization rates in a community. Those data are interestingly, surprisingly hard to come by, but we've been scraping them up, and immunization rates, particularly for toddlers. But that'll be interesting for us to look at, and we're also looking at some morbidity outcomes as well. Also with communicable disease, we're looking at, with these immunizations data, as we pull together, we'll have fewer years because the good immunization data are just a couple of years of data, but we'll have more states now with New York being added, and if there are other states that we can add along the way, it gives more power to our analyses. So in terms of fast finance, we've also been, I briefly mentioned, we've been including these 3 latent classes of local health departments. That's a whole nother area we've been going down in terms of having a way to incorporate some value or indicator of the health department's basic approach to public health services, the degree to which they're more narrowly focused or more comprehensive. A lot of that depends on what else is going on in that community. We'd like to include improved data, as I mentioned, around other types of services, and ideally if more states are collecting improved data, and over time there will be a lot we can do with that. We also want to do some work with the big buckets. When I say a big, the instead of the specific expenditure areas, but the annual funding for maternal child health in general, and for environmental health in general, and CD control. and looking at before 2008 and after 2008 for these 4 or 5 states. We've got annual data, so we'll be looking at that. And been doing presentations around this. We keep up to date with our practice partners as much as possible. We'd love to do more of that. Meeting up with our state partners. This study will end at the end of May. So there's more to come, and we've been exploring these data, and that's what I've been talking about here today. But we're really getting to where we're honing in on a few areas where we'd like to look at, be able to really describe some things around these data. Here are some of the papers we've gotten so far and that are under review. And I can never end a talk without saying thank you to the FAST bus. We say, Jim Collins says, great teams have the right people on the bus, and that's really what FAST is all about. We make jokes all the time about our FAST bus, both our research team here and our partners around the country. We're very grateful for them. So I'd like to kind of stop there and mostly just kind of hear what people have to say in terms of questions or thoughts about these data, or things you think would be really interesting for us to do with these data going forward. We're always interested in ideas, particularly from our PBRN partners.
Thank you very much, Betty. I've opened up the microphone lines. If you want to ask a question, you should be able to do so. If you somehow do not have audio, please feel free to use the chat box, and I will just say your question out loud.
Hi, Betty. This is Scott Frank from Cleveland. I'm wondering, particularly because I'm doing a review of some of your instruments right now, how do you parse expenditures between your your communicable disease program and your epi-surveillance capability, foundational capability, since from my perspective, communicable disease control requires the surveillance component. And how does that compare with how the other states divide or combine those same sorts of services?
Yeah, you hit the nail on the head for us, Scott. That's something we've been really dithering over here in terms of, and that could be one of the limitations I mentioned. It's been hard for us to really see the relationships that we were hoping to see. We knew it would be hard, and it is hard. But nonetheless, there's a lot we've done with this data, so we want to get the full, make sure we get out there what we have. But you're right, the surveillance piece has been hard for us to capture. There are, some of the states have an expenditure line around surveillance, so you have a sense of the degree to which they're investing in particular communicable disease surveillance or not. One or two of the states in this study have a larger, such a large surveillance expenditure line that includes a lot of other things aside from, enteric disease and communicable disease. So have been playing around with that, and you just kind of reinforced that we need to do some more looking. There's sometimes we've included data from the NACHO profile that says the degree, it doesn't say any kind of measure of amount. It just says whether or not a health department is doing surveillance or communicable disease control or EH-related surveillance. It doesn't say how much of it, so it's a more blunt measure. But that's definitely been something we've been looking into and kind of struggling with. Do you have any ideas?
Well, yeah, I mean, I actually in Ohio, we would divide epi investigation from surveillance, and the surveillance would be more BRFSS and WireBS kind of measures, while epi investigation would be more specifically communicable disease surveillance and investigation.
Mm.
But this defines one of our major problems, and that is how it is that we um, divide things in the different states. Depends on more than just the words we choose, but also the policies in the state and differences in populations, which I would suspect is a major difference for Minnesota, as they describe their communicable disease is a pretty different population than some of the other states, in particular with a lower poverty gap in Minnesota than other states.
And some of that, certainly the population characteristics and some of that we can capture, we can control for that. The policy differences we have to be aware of and take it into consideration, and as part of how we interpret what we're seeing, et cetera. It's hard to, but it's what's been great for doing this through with the PBRN, so that we have, so that we can talk about some of those policy differences and be aware of them. It's not always easy to control for them.
Right.
In this epi and surveillance piece, this is why we're excited in part for the improved data, because the more we have and can pull up in terms of activities and service statistics around what people are actually doing, that gives us more to work with, and that's where we might be able to get some measures of surveillance, et cetera. Perhaps not for this study, because we won't necessarily have not been able to find much data around that for this group of states, et cetera. But it's it's on the horizon as we get more of these service statistics together as well. That's another way to control for that.
Thanks, Betty.
Uh-huh.
Betty, Susan has a question, regarding the same issue of getting comparable data. Can you see it in the chat box? Would you like me to read it out loud?
In the chat box.
I can go ahead and read it for you. It's on the would be the bottom right hand gray box.
Okay.
Yeah. She says, great work, Betty. For the 44 other states that aren't contributing data, do you have any plan to provide a template or model way of collecting data at the local health department level so that comparable data can be provided? Sort of a, if you want to participate, this is what and how the data must be collected type of thing.
Oh, wow, music to our ears. There's a lot of efforts underway. First off, we're interested, we're eager for data. So if those of you who have been, who do have detailed financial data and or service data or service statistics, we'd love to talk. So please email me. And we'll have opportunity to be able to work with your data and work with you together. I mean, the work we've been doing with these data have turned out to be very helpful for our practice partners too, and that's what's kind of rewarding here. So hopefully folks see it as a give and take. But also there's larger efforts nationally around a chart of accounts, around developing some standardization about how some of these financial data should and could be collected in some standardized way across states. So there's definitely a larger state-level effort, and surely Glenn can talk to that, can speak to that as well. Also around service statistics. the Improve study kind of helped kick some of that off in terms of what should people be collecting going forward if you've been collecting data already around service statistics. It'd be interesting to see what you've got already. Some people have done, a few states have done well in that already. But as we standardize what we collect going forward, we've gotten to start with that with Improve, and some of us will be working on expanding that, getting more standardized data from more states around, again, service statistics, not just the expenditure side. So, and I'll be working with states around some of that going forward. Some of what we're doing here, too, is, what I just presented in part, is to really help fire up the dialogue around what data are out there and what we can really do with data when we've got good data that's comparable, et cetera, and what the potential is, where the problems lie and what the potential is for what we can do with these data. So the degree to which that gets people talking, how do we standardize our data collection, that's music to our ears. And I don't know if Glenn is there yet. Lizeth or Glenn, you want to jump in? Maybe he's not there yet.
Yes.
There you are.
Can you hear me?
Yes.
I'm here. I'm dropping in virtually. I'm sorry for being late. I'm calling in from the Robert Johnson Foundation's big meeting on QI and public health in Memphis. And I've just heard the tail end of Betty, your comments, and I think what I can say first and foremost is that that I think you're absolutely right on. I think we're through the work that FAST is doing and the work that we're achieving now through Improve. We're kind of showing the proof of concept of what kind of research we can do with as we make progress toward aggregating data across settings, across states and communities, and importantly, as we make more progress towards standardizing how we measure key elements of service delivery, how we measure key elements of public health spending, and now as we measure key elements of the costs of delivering public health services through our the DAX projects that are now being implemented through PBRN. So I think all of this, all of these activities are kind of pointing in the same direction: FAST, Improve, and in DAX, in terms of leading us toward being able to standardize ways of measuring public health activity, so that we can make more meaningful comparisons across public health settings in terms of the scope and scale of public health delivery, the cost and resource requirements required to do that, and ultimately because those are the building blocks for ultimately being able to answer questions about value in public health delivery. So I'm right on target with those issues.
And our feeling has been sort of, it's kind of iterative, right? The people aren't necessarily going to necessarily all get the idea that the effort that goes into standardizing data and collecting data is really worth it until we start doing some things with the data and show what's really possible. And yet it's hard to do that when the data aren't there. So we've had this kind of iterative process, and that's how FAST has been launched here in terms of working with some of the existing data to really show what's possible and what the potential is, and at the same time, identify some of these gaps in the data, and therefore help to also further fire up this dialogue around what kind of data, or the importance of collecting standardized data, and how and why and what it ought to look like, et cetera.
There's a similar question from Dawn Marie Jacobson, Betty. She says, nice to hear about the great work. Have you analyzed your performance data using the accreditation domains?
Not specifically yet. And definitely, we look at there are some performance data. We haven't really had a lot for performance data that we've been using or pulled in yet. There are actually some sort of performance-related items in the improved data we're interested in pulling in. That's definitely, Dawn, on the radar screen. We haven't gotten there yet, and hope to. We just started the FAB Research Advisory Council was recently formed, and there might be some questions that comes out of that group too that will help kind of leverage additional research through FAST with that. We'll see.
Thank you. Any additional questions? Okay.
And Lizette, just to leave off that, we're always interested in working with states who want to collect more standardized data, particularly services data, and or talk about how to do that. Feel free to email me, and for those with data that you think might be of interest to us, and we could work together, give me an email as well. Also, researchers who are interested in collaborating around opportunities, we want to make these data available to our PBRN partners. So, and these data are all linked by health department to many other variables, and we can talk about making those data available to you to do more with as well.
Excellent. We'll be happy to help broker any of those partnerships as well. Just contact us here. One more question from Dawn. If a large city wishes to work with you on FAST, would that be possible?
Yeah, let's talk. We've been mostly working, our focus has been on local health departments and across a whole state. But yeah, let's talk. There's lots of potential. There's stuff I'm doing with some folks here in Seattle for the Seattle-King County, for example. But there's potential. Sure.
Thank you so much, Betty. Okay. Thank you. We're going to move on to our agenda. And Glenn, before you start, since Kate Papa has limited time, I'd like to move her up from the bottom of the agenda to the top of the agenda. She wants to talk to the networks about the Academy Health Scholarship to the annual research meeting. Kate, are you on?
Yes, I am. Thank you so much. Thank you so much. I'm always so excited to be invited to these calls, and I joined late, so I only heard a little bit of that great work that Betty was talking about. But I about fell out of my chair when I thought she was going to be able to read that chat box. So I'm quite relieved that Betty still can't read the chats. Some things never change. So this is Kate from Academy.
I was busy tweeting.
Oh, Betty. This is Kate from Academy Health, and I just love talking to all of you. So thanks for inviting me on the call today. And this is just a very quick announcement that we, Academy Health, is going to be doing the scholarship program again in 2014 to provide scholarships for PBRN scholars to attend our annual research meeting, which is this year in San Diego, June 8th through 11th. So if you're not familiar with this program, last year was our first year, and I think it went really well. So we're working together with the coordinating center and also taking some great feedback we got from last year's scholars to refine the program a little bit. But it's a scholarship program which will pay for your travel costs and the registration fees to come to the annual meeting, and also the interest group meeting after that in San Diego. And we will be releasing that call for applications applications hopefully in December. So I'm sorry I don't have the actual dates right now. We're just realized that it might be better to get this out sooner rather than later. We know how busy everybody is, and we want to give you a little bit longer time frame to apply this year. But we're trying to keep the application pretty simple so that you're not too intimidated to actually just put pen to paper and tell us why you'd like to come. And we do want to encourage pairs from the PBRNs to come. Last year we just had a couple of pairs, and I think it was a really great experience for the researcher practitioner or the senior researcher, junior researcher, or whoever your pair may be, so that you can attend the conference together. And again, our annual meeting is our sort of large scientific meeting, and there's a great chance for you to come and learn about emerging research, research methods, and we also have a fair amount of presentations about linking research to policy and career development and how to get published and all other kinds of sessions. So I am very excited that we're going to have this scholarship opportunity again this year, and I'm just kind of teasing it up today to hopefully encourage folks to apply. I'll rely on the University of Kentucky to help us get the word out, but I'm inviting anyone with any questions about the materials once they're sent to just please reach out to me personally. Just give me a call or zip me an email, and I'm happy to talk through the conference more with you and what I think you could get out of it and why you should apply, and any questions you might have about the scholarship.
Thank you so much, Kate. And I just want to reiterate what wonderful feedback you received from the scholars from last year. It was just a wonderful experience. We had them come present in a virtual meeting like this, and it was just very, very interesting to hear from them and hear what each different group took away. So it really is a wonderful opportunity. We want all of you to consider it.
Yeah, and I think what I learned a lot of great things from that call, so I was excited to be invited to that because I didn't know you were going to be critiquing the meeting, and I was pretty shocked to be invited. But I did share the comments with a lot of folks here at Academy Health because, of course, we're always looking to improve. But I thought one of the most interesting things about last year's scholars was, it's kind of a range of folks. So some of you seem to really go to the methods-focused sessions and really were working to do more rigorous research on your own, and some of you are more interested in sort of the policy implications. So I think all of the scholars kind of were hoping to get something different out of the meeting and kind of came for different reasons and went to different sessions, and that's fine. We're hoping that you get what you need to get for your own professional development out of the conference. So we hope to be able to meet the needs of a range of people across the research and practitioner spectrum, and also sort of more folks who are just kind of entering the research community and those who are, who've been researchers for a while. So again, thank you so much for allowing me to talk about this today and for your continued support. And I always love hearing about the PBRN work. So once the materials are out, again, I just invite folks to give me a call if they have any questions.
Thank you so much, Kate, and we appreciate you taking the time to talk about this again. Thank you so much.
Yeah, thank you.
All righty. Glenn, are you still on?
I am.
Do you want me to hand things over to you?
Sure. Why don't I've got, and my only limitation is I don't have a lot of time either. Unfortunately, I'm going to have to slip back into the meeting here in a little bit. So if you don't, so I'll say it if that's okay. I'll take a few minutes and then can I hand it back over to you, Lizette?
Sure, of course.
Excellent. Well, again, thanks for being with us. I'm again calling in today remotely from RWJ's Open Forum meeting on quality improvement, which is a great program they have been sponsoring for a couple of years now to facilitate applied work in quality improvement in public health. And I've been hanging out with many of your colleagues, actually. We've got stakeholders from a number of our PBRNs represented here today. In fact, I just got off a panel with some of our colleagues from Ohio and from RAFI, who are involved in RAFI's studies around cost estimation, and now the new delivering cost study, the DAC study that's being implemented in Ohio. So Ohio is well represented here. Colorado, the members of the PBRN in Colorado are well represented here. And who else have been hanging out with this morning? Washington State. Betty, a number of your colleagues are here as well. So the PBRN research has been mentioned numerous times already this morning. So I thought you all would want to hear that who've got colleagues here in Memphis today. A few other issues, and I'm kind of flying blind with this, so things that I don't mention, please, I may not follow exactly on the agenda that we talked about because don't have it in front of me. But a couple of things to note. One is on the research front, we want to thank a number of our PBRNs who worked with us over the last couple of weeks to develop a proposal to CDC under their solicitation for injury control research centers. As we've talked about for the last couple of months, that call for CDC-funded injury research centers has been out in the street for several months, and we were interested in regional centers with a regional focus, so we were able to pull in some of our neighboring public health PBRNs who operate in the Appalachian region here to go in with us, collaborate with us in support our application for an Appalachian-focused injury research center that has a strong PHSSR and PBRN flavor. So that application went in a couple of weeks ago, I think the first week of November, and we want to thank our Ohio network, RAFI, for supporting that. We want to thank our two of our newer PBRNs to join us, our Alabama PBRN and our Virginia PBRN, for joining us in that effort. Our Tennessee PBRN, thanks to our colleagues there. And obviously our Kentucky PBRN. Those are, I may be leaving somebody off, but I think those are some of our Appalachian-based PBRNs that joined with us in that effort. So it'll be a few months before we know about the funding for that, but we'll keep people, we'll keep this our PBRN community posted on that. Obviously, we've had an ongoing dialogue and collaboration with CDC's Injury Center about their interest in getting more, supporting more PHSR focused on injury prevention and control delivery. Again, we think the PBRNs are a good vehicle for getting that kind of research underway. So this proposal might give us one mechanism for getting more PHSSR and PBRN research underway with CDC support focused on studying injury prevention and control delivery through public health settings. So thanks again for your help with that. In terms of other research funding, just to keep in mind, and there are two things that have come up just in the last couple of weeks to be aware of, and these funding announcements obviously will be profiled in our newsletter. One is a call that was issued just last week, a new funding announcement from NIH, the multi-institute funding opportunity designed to fund pragmatic trials in both healthcare and public health delivery, in particular using networks of existing practice settings to fund pragmatic trials studying the effectiveness and efficiency of a wide range of health interventions. And this call in particular specifically highlights both public health and prevention strategies as well as healthcare delivery strategies. So this is an opportunity that our PBRN networks might be particularly interested in thinking about the use of PBRNs as infrastructure for organizing pragmatic trials. So that may be one opportunity that you want to take a look at that may be of interest to our PBRNs in particular. A second second announcement, just a funding opportunity, the CORI, which is an institute that we've talked about over the months because of its potential relevance in terms of funding studies in public health delivery and looking at public health delivery systems. The CORI just announced earlier this week their kind of next round of their funding expectations, just coming out of their board meeting that wrapped up last week. And so, as expected, the CORI is fastly becoming one of the dominant funders of health-related research. They're expecting over this next year to fund upwards of $500 million in new extramural research projects. And so, just a reminder to keep the CORI in its announcements, its funding opportunities on your radar for PBRNs. We've also had some ongoing discussions with the CORI about their interest in again studying public health delivery alongside the other health interventions and delivery system interventions that they're charged with studying. And they're clearly have a mission that spans into prevention and public health as well as clinical care and therapeutics. And so just a reminder to keep the CORI's opportunities on your radar, particularly now, because they are scaling up. We're in the high growth years now for CORI, where the amount of research dollars they're giving out are really substantial now, and they're increasing as contrasted with a number of our other federal research funders. So keep an eye out for that. A couple of other exciting things to note. We have a special theme issue on PBRN research, which is finally now becoming available in the American Journal of Preventive Medicine. Officially, this theme issue appears in the December issue, but these articles, I believe, are already available early online on the AJPM website. And so for those of you who contributed an article, great work, and thanks so much for being a part of this. For the others of you in the PBRN family, you'll definitely want to take a look at these great papers. I think we've got a set of five articles, all focused on research that has been conducted through our public health PBRN programs. Many of the studies that are part of that were funded as part of the Research Implementation Awards that were completed, were one of the first iterations of larger scale research projects that we funded through the PBRN program. And so we're excited to see that in print now. There's a nice overview, kind of editorial article that we wrote with some colleagues who are involved in the PRC program at CDC, the Prevention Research Centers program. And so that overview editorial kind of talks about some of the collaborations that are happening between public health PBRNs and prevention research centers, but it also lays out some of the kind of future opportunities for collaboration between these two different types of research networks in public health. So keep an eye out for that. If you haven't seen that theme article, we've got in addition to that overview article, we've got a paper from Kentucky Network, a paper from Wisconsin, a paper
New York.
Thank you, New York.
Washington.
In Washington, yes, one of Betty's favorites. And so it's a great set of papers. So definitely check those out, and we'll make sure to highlight those in the next newsletter as well. With that, I'm probably going to have to run back into the open forum meeting here. So, Lizeth, is it okay if I hand the baton back over to you for?
Sure, that's great. Thank you so much. Yes, absolutely. Thanks for stepping out, Glenn. Really appreciate it.
You got it.
Thank you. So just a couple more items to discuss. I just wanted to give everybody an update on the DAC study. As you know, this is our delivery and cost study that we've been referring to both in Betty's presentation and later on in the conversation. But we are at the level, we have now, everybody has turned in their protocols and instruments, and we are peer reviewing those protocols and instruments. And we are going to have those reviews are actually due tomorrow. And on Tuesday, we will meet again, just the DAX team, to have a discussion on the reviews of those protocols and instruments. Let's see, additionally, just a quick debrief on the APHA. I know many of you were there, and as always, it's a very hectic but wonderful meeting. We did prepare a list of all the PBRN presentations, and it was combined with the PHSSR presentations. I think that we might have left some people off of those. I know I've spoken with some of you, so if you were not in that list, or if you don't have that list, I'll be happy to send it to you. We really would like to have a complete list of all the presentations so we can submit that to the foundation. It's important for us as well as for you all to be on that list. And sorry, it looks like we're going backwards in this agenda, but a formal welcome to our new PBRNs, both Alabama and Virginia. Virginia has been on board for the last couple of months, but I don't think we were officially welcomed you, and Alabama is pretty new. So welcome to both of you. Let's see, what do we have left? Dissemination opportunities. As always, we have Frontiers, our open access journal, very fast review times. We highly encourage you to please submit short manuscripts to this. We can provide you with additional details, although most of you know about it. I also wanted to let you know that the call for abstracts for the Keeneland Conference and our PBRN grantee meeting will come out in the next couple of weeks, so be thinking about that. It's a great opportunity to disseminate your findings, both to the PBRN networks and to the broader PHSSR audience. The quick strikes. We have finished going through the first set of reviews for the quick strikes. We will start reviewing again probably in February, so if you have not sent in your quick strikes, please go ahead and submit those. Let's see, and we talked about the Academy Health Scholarships. I think that covers everything. Are there any questions? Okay. One other thing, I did want to thank everybody for your reports for the IMPROVE study. Thank you so much for getting those in on time, or close to on time. I know we had a lot of the data analysis is taking place pretty late, so there are not a lot of products associated with these grants right now, but please, as soon as you, don't forget that we still want to see those products. So as you start writing your manuscripts and presenting additional meetings on your results, please don't forget to submit those to us as products. And as always, send them to me. I'll be happy to look them over, make sure they meet the correct naming standards for the foundation, and we will assist you with all of that. Okay. If there aren't any questions, then, oh, hold on, I think there's a question. Yes, the specific deadline for the quick strikes. Let me send that to you. I will send that to this email list as soon as I get some more additional details. I don't remember what the exact deadline is, and we have pushed the deadlines back a little bit, so I don't want to give you a date and have it not be correct. But I will send that out in an email. Who is funding the pragmatic trials? As Glenn mentioned, it was an NIH multi-institute effort. I'll have to look into that, Scott, and let you know. Honestly, this is the first that I heard of those, so I will get back with you on that as well.
It's probably out of the DNI.
Oh.
I don't know. I'm not sure what institute, though. Sorry.
Okay. I'll definitely look at that and get back to you. Any other questions? All right. Well, hearing none, then it looks like we're ending a little bit early today. I'd like to thank everybody for joining. Thank you again, Betty, for a great presentation. We appreciate hearing about everything.
Happy to do it. Thanks.
All right. Thank you, everybody.
Thank you.